Thank you, Mr. Chairman. Ladies and gentlemen, I'd like to thank the organizing committee for the opportunity to present this case, and actually it's an example of which Professor Jacobs was just talking about. I'm presenting to you a case of a fit 74-year-old man with mild COPD and cholecystectomy in his medical history. He had a complicated type B aortic dissection in 2003, for which he was treated with an endovascular iliac fenestration and stenting in another center, and was referred to our center for further follow-up, entered our follow-up program. And during the years we saw his thoracic part especially dilating, and in the last year it dilated from approximately 6 to over 6.5 centimeters with a good renal function. Which you can see here in the 3D reconstructions, mainly the thoracic part was dilated. And the interesting part is that all his visceral vessels were originating from the false lumen, and both his legs were perfused from both the false and the true lumen. Complicating factor was that his true lumen was for an important part thrombosed, making an endovascular approach in the true lumen difficult. So in the balance, we felt he had a significant risk of rupture, so we felt we need to do something. So wait and see was not a good option. All visceral vessels were originating from the false lumen, the true lumen partially thrombosed, and the iliacs were fenestrated. We felt that a hybrid approach was not a good option for this patient, because we would expose him to all the risk of endovascular procedures and the risk of open surgery as well. We might opt for open or endovascular. And in this case, we opt for a staged endovascular approach, in which we would treat the thoracic part, the large dilation first, with a custom-made endograft from the aortic arch down to the iliac bifurcation, with one branch for the sleeve trunk and 3 fenestrations, SMA in both renal arteries, and we would place it in the false lumen. As I said, the true lumen was not good accessible. And we would place an occluder, a candy plug, in the true lumen going up to the thoracic part in order to do a staged approach, so have the false and true lumen perfused in the abdominal part, and only occlude the false lumen, the true lumen in the thoracic part. And perioperatively, we would do a temporary experimental occlusion of the candy plug to see how his maps were doing. So this was the schedule of the graft. There was a tapered tube graft coming from the arch. Then we would proceed with the fenestrated and branched part, and we had an infrarenal abdominal part with an inverted leg because of the length of the complete system. And this was the schematics of the candy plug for the true lumen. So we performed endovascular treatment, 1 branch, 3 fenestrations in the false lumen candy plug, of course using maps and a spinal tap. When we occluded the candy plug, we saw no changes in this map, so we occluded the candy plug definitely with a plug. You can see the experimental occlusion. Right next to the graft, you see the transesophageal ultrasound from the anesthesiologist. Postoperative, no spinal cord ischemia. Segmental infarction of the left kidney and the spleen without clinical consequences, so good clinical and biochemical recovery. The patient was discharged after 7 days. And you can see the candy plug over here occluding the true lumen, and in the 3D reconstruction postoperatively you can see the almost full metal jacket going down from the arch. And you can see let me see if I can show you. You can see the true lumen filling up to the candy plug over here. So this part, all the lumbar arteries are still perfused, both legs are still perfused, and the hypogastrics are still in the circulation. And in the future, if the abdominal part was going to dilate, you might opt to extend the endovascular procedure towards the external iliac arteries and occlude the lumbar arteries in a stepwise sequential fashion. But up until now, this was not necessary. You can see the occluded kidney plug in the thoracic part. So, current status, treatment of chronic type B aortic dissection with progressive dilatation can be treated endovascularly with selective occlusion of one or true lumen for a staged approach. In our hospital, we have used the kidney plug now in 2 cases. In one case, we occluded the false lumen, in another case, the true lumen with excellent clinical results. Global experience now is the kidney plug is a few dozen cases, and the update from the kidney plug is now, from Cook at least, is that it has a separate closing device in the plug as well, so you do not need to put an implanter inside. Thank you for your attention.